Shalom, this is Graciela Salinas, and I welcome you to another episode of the biomedical devices that we use in the United States. In the back, you're seeing San Antonio, where hopefully you will be working next year and celebrating Nurses Week with me. I don't live in San Antonio, but I'm fairly close, about maybe 3.5 hours. But this is the skyline you will be seeing whenever you come to work in San Antonio. I hope that will be soon. But let's talk about the stethoscope. This is a piece of equipment that you should own, that you should have, because how do you do auscultation if you don't have a stethoscope? For the NCLEX, there are 3 areas that you need to auscultate: lungs, heart, and GI. You need to know for sure what are you auscultating and what you're looking for. So let me share first a little bit about this stethoscope. Of course, as you can see, it's a Lippmann. It's one of the best in the industry. And sometimes we need the best, especially if we work in cardiology and we need to listen carefully to the murmurs and to the S1, S2, S3, S4 sounds. Then we need the best. So it has the diaphragm on this side, and the other side is smaller, as you can see, and that is called the bell. Okay, and this is just a regular stethoscope, except that it has this part right here. This is an amplifier. So there are several things about this. If I turn it on, what it will do, of course, I will see the light blinking. That means that it's on. And it will do noise canceling so that I can really concentrate on listening to whatever I'm hearing. And it also amplifies the sound so that I can hear better. But not only that, it is connected to an app that I have on my phone. And in the app, I can actually see the sound, almost like an EKG, but it's giving me the frequency, the amplitude of the sound so that I can see it and I can identify murmurs a lot better. If I have a question about, is this really a murmur? Is it an innocent murmur, which are the ones kind of hard to hear? In the graphic, I can see if it's actually an innocent murmur. A pathological murmur, no problem. Anybody can hear it. Sometimes you can even hear it without a stethoscope. But that's the beauty of this stethoscope. Now let me share screen to show you how we're supposed to be doing assessments. And I'm going to move from here. Let me move from here. There we go. And now, now you can see the chart so that you can start doing your assessment. So at a minimum, you have to listen to the 4 basic auscultatory sites. First, whenever you do it, you gotta use your diaphragm, and then you can switch to the bell. But with this stethoscope, all I have to do is change frequencies, and then I don't have to even move my piece. I can just stay there and try to look for the frequency that better gives me, or that where I can hear the noise better. But for you who are young, who are pretty, who are still have a pretty good ear, you don't need this. You can do the switch. So we say in nursing, ape to men, to remember where we should be putting the stethoscope. So for ape to men, it's 1A, that will be the aortic valve. Then we go to the P, pulmonic, and the A will be on the second intercostal space on the right side of the sternum, aortic. We hear S2 much louder on the aortic valve. For the pulmonic, that will be on the left side of the sternum, same place, second intercostal space. Then we jump 1 space and go to the 4th on the left side, and we hear the tricuspid valve. Now we hear the S2 sound much louder. And finally, on the 5th intercostal space, mid-clavicular line, that's where we hear the mitral valve. So as you can see, On 3 and 4, we can hear S1 louder. So S2 will be heard at the aortic and the pulmonic valve much louder. S1 will be heard at the tricuspid and the mitral valve louder. I hope I didn't get you confused. S2 on 1 and 2, aortic and pulmonic. S1 on tricuspid and mitral valve. In the middle, right here on this empty space, is what we call Erb's point. Erb's point is on the third intercostal space to the left, in between the aortic and the pulmonic and the tricuspid valve. And that's where you can hear S1 and S2 much, or equal, not louder, but equal, is S2 and S1, equal. Okay, and remember, S2 is the closing of the aortic and the pulmonic valves. S1 is bigger, is louder, because it is the closing of the tricuspid and the mitral valve. So in the United States, in English, we say that the sounds are distinct. You cannot get confused between the S1 and S2. So we say that is lub dub. Lub being the S1, dub being S2. So you will hear lub dub, lub dub, lub dub, lub dub. And then the murmur is, I don't know, like something that is scratching against the wall. So you will hear something like lub dub, lub dub, lub dub, lub dub, lub dub. If it is an innocent murmur, you may have a hard time hearing it, but if it is a pathological, you'll hear it perfectly. So now let me go to the auscultation for the lungs. And as you can see here, you have to know the anatomy, and you know that the right side of the body, the right lung has 3 lobes and the left side has 2 lobes. So you will have to listen to everything. And what you do is you do a zigzag. Try to stay away from the bronchial tree, unless you want to hear bronchial sounds. But we're looking for vesicular sounds, the ones that are away from the tree, because that's where we can hear the rhonchi or the absence or the diminished. That is where the alveoli is exchanging air, and that's where we want to be. If you want to hear whistle because of asthma or some kind of constriction of the bronchial tree, then you can go to the bronchial tree. But again, sometimes you don't even need a stethoscope to hear the wheezing from the patient. So what you do whenever you're doing a lung assessment, you're going to do a zigzag. You're not going to do one side first and then the other. You go to the upper area first, and then you go across and check the left. This being the right, this being the left. And keep on going down. And then you listen to one side, and then you go across to the other side. So you can compare how the left lung sounds versus the right. And you will document it in such a way that maybe they are similar on both sides, on left and right, or maybe that they are diminished on the right side, lower area, lower lobes. Remember 3 and 2, 3 on the right and 2 on the left. So you will come to the basis. That's where you expect to hear the diminished or even absent sounds if the person has a pathology like pneumonia or anything like that. Then you will listen also to the side, in the axillary area, and go across to the other side. How will you document it is that you heard bronchiovesicular if you listen to the bronchial side, but mostly that you heard vesicular sounds present in all 3 lobes on the right side and the 2 lobes on the left side. There was no diminished or absent sounds in any lobe. And that's how you will document that is normal. Please don't use normal sounds because that is not, you don't give us enough information. Describe everything and then let the reader know what you're, or make a discernment of what's going on. So the other side, and I don't have a graphic for that, so I'm gonna stop sharing The other side is not the other side, the other area is the GI. So we just imagine the abdomen, and I don't know if I can stand up. No, even if I stand up, you cannot look at my abdomen, but look at the abdomen, and from the belly, you're gonna do the 4 quadrants. And you're gonna say upper right quadrant, lower right quadrant. And actually when we abbreviated, we just say RUQ, right upper quadrant, or RLQ, right lower quadrant. And then we go to the other side and we say LUQ, left upper quadrant, or LQ, left lower quadrant. So you have the 4 quadrants, and that's where you will put your stethoscope on those imaginary lines in the quadrants that you have divided, so that you can hear vowel sounds. So you expect to hear a vowel that is active. You expect to hear vowel sounds present in all quadrants. It's how you're going to describe it, unless there is more active in one area than another, then you say that the vowel sounds were more active, were more active in whatever quadrant than the other. Especially if there is diarrhea, you're gonna hear a lot of activity. If there is, if the person has been without eating or has been after surgery, you may not hear any sounds in the GI tract, but you have to document that. Okay, I think I have spent enough time with you. I hope you're having a good time during this week, and I will see you next time. Shalom.